Assalamualaikum warahmatullahi wabarakatuh. Selamat pagi dan salam sejahtera bagi kita semua. Perkenalkan, saya Raden Achmad Candra Putra, dosen tetap pada program studi Sarjana Terapan Ortotik Prostetik, Jurusan Ortotik Prostetik, Poltekkes Kemenkes Jakarta I. Pada kesempatan ini, saya akan menyampaikan pembelajaran pada mata kuliah Concept of Transfemoral Prosthetic dengan topik Ischial Containment Socket Measurement and Casting Technique dalam rangka pernyataan diri dosen dalam unjuk kerja Tri Dharma Perguruan Tinggi PDD-UKTPT dalam aspek pengajaran sebagai syarat Sertifikasi Dosen tahun 2026. Mata kuliah Concept of Transfemoral Prosthetic merupakan mata kuliah yang dirancang untuk membekali mahasiswa dengan kemampuan memahami konsep manajemen prostesis transfemoral secara komprehensif, mulai dari aspek anatomi, biomekanik, asesmen pasien, formulasi resep prostetik, prosedur pembuatan prostesis, hingga evaluasi hasil pemasangan prostesis berdasarkan praktik berbasis bukti. Pelajaran pada mata kuliah ini mendukung pencapaian beberapa program Learning Outcome atau PLO, program studi Sarjana Terapan Ortotik Prostetik yaitu PLO nomor 4. Lulusan mampu memberikan pelayanan ortotik prostetik custom made kepada pasien dengan kasus kompleks dengan memanfaatkan ilmu pengetahuan dan teknologi sesuai standar pelayanan ortotik dan prostetik secara komprehensif, profesional, dan berbasis bukti. Adapun capaian pembelajaran mata kuliah atau course learning outcomes yang akan dicapai pada mata kuliah ini meliputi CLO 3. Mahasiswa mampu menganalisis prinsip-prinsip teoritis prosedur prostetik transfemoral yang meliputi proses casting, rectification, fabrication, dan fitting. Pada sesi pembelajaran kali ini, topik casting procedure for ischial containment secara khusus mendukung pencapaian beberapa learning outcome sebagai berikut, yaitu LLO nomor 3. Mahasiswa mampu menganalisis konsep casting, prinsip desain soket, pemilihan material, serta teknik rektifikasi yang berpengaruh terhadap kenyamanan, stabilitas, dan luaran fungsional penggunaan prostesis. Setelah mengikuti pembelajaran ini, mahasiswa diharapkan mampu 1. Menjelaskan prinsip biomekanik ischial containment socket pada prostesis transfemoral. 2. Mengidentifikasi landmark anatomi yang diperlukan dalam proses casting. 3. Menganalisa tahapan prosedur casting berdasarkan prinsip biomekanik dan soket design. Yang keempat, mengevaluasi kualitas hasil negatif cast sebagai dasar dalam pembuatan soket prostesis yang optimal. Selain capaian pembelajaran yang akan dicapai, pada mata kuliah ini, mahasiswa akan dievaluasi melalui beberapa metode penilaian yang dirancang untuk mengukur penguasaan pengetahuan, kemampuan berpikir kritis, dan komunikasi ilmiah, serta kemampuan analisis dalam bidang prostetik transfemoral. Komponen penilaian pada mata kuliah ini terdiri dari UTS sebesar 20% untuk mengukur pemahaman mahasiswa terhadap konsep-konsep dasar prostesis transfemoral, Final Examination UAS sebesar 30% untuk mengukur evaluasi kemampuan mahasiswa dalam mengintegrasikan dan menganalisis materi pembelajaran secara komprehensif, kuis sebesar 10% yang akan dilaksanakan secara berkala untuk mengukur pemahaman mahasiswa terhadap materi yang telah dipelajari, dan ada oral examination sebesar 20% untuk menilai kemampuan mahasiswa dalam menjelaskan konsep, melakukan penalaran klinis, serta mengkomunikasikan dalam mengambil keputusan berdasarkan kasus yang diberikan. Selanjutnya, ada scientific paper presentation sebesar 20% yang bertujuan dalam mengembangkan kemampuan mahasiswa dalam melakukan telaah literatur, berpikir kritis, serta mempresentasikan hasil kajian ilmiah secara profesional dan berbasis bukti. Dalam pembelajaran ini, mahasiswa akan mengikuti kegiatan pembelajaran yang mengintegrasikan pendekatan case-based learning serta diskusi interaktif untuk mengembangkan kemampuan clinical reasoning dan keterampilan profesional yang diperlukan dalam pelayanan prostetik transfemoral berbasis bukti. Baik, mari kita simak pembelajaran pada topik casting procedure for ischial containment socket. Okay, good morning everyone. How are you today? You're fine, thank you. So today we are going to continue our study, the topic that continued from yesterday. So yesterday we have learned the introduction of the ischial containment socket. Now we are going to more proceed how we're going to taking cast of the patient's thumb with the method of ischial containment socket. So program learning outcome that we have from this topic is supporting the program learning outcome number 4, which is the graduates be able to delivering custom-made orthotic and prosthetics. And it support the course learning outcome number 3, which is you'll be able to analyze theoretically principle of transfemoral prosthetics procedure, especially this point, casting for the ICS socket. And then the lesson learning outcome is also supporting number 3, which be able to analyze prosthetic material, fabrication principle, casting concept, and rectification technique. But we are going to be more focused on the casting concept. This topic is about casting of the ischial containment socket. At the end of the session, you will be able to explain first how to do a measurement of the ICS concept, and the second one, you'll be able to understand the procedure, how you're gonna do casting for the ischial containment socket. Okay. So content of the topic presentation, like measurement techniques, casting technique, and how you will prepare for the rectification. Before we proceed to this one, let us to discuss the review the previous topic. Yeah, what do you think the weakness of the quadrilateral socket, which cannot be accommodated, and then what would be the effects of the quadrilateral socket as we compare to the ICS one? Anyone could answer this one? What will be the weakest point of the QL socket as compared to the ICS one? Anyone? Okay. Octavianus Agung.
Okay, allow me to answer the question. So the disadvantage of QL socket is instability of pelvic because during lifts the ERF goes medially and it makes the MP goes move laterally and the femur bone goes laterally as well. So during this, the hip adductor muscle is shortening and it makes the pelvic drop to unsupported side. So this leading compensate the trunk to lateral bending supported side.
Okay, excellent. Right. Give applause to Agung. Okay, thank you, Agung. So I want to confirm one thing. That so the pelvic is going to slide medially. Is going to slide medially while the GRF is located medially of the hip joint where it creates abduction moment. Yeah. When the pelvic medially slides, it makes the lateral movement of the femur. When the femur goes to laterally, it makes hip abductors muscle become shortening. So that's why it's less effective in order to make the pelvic in the same level. Okay, but excellent, Agung. So we're gonna start continue after you understand the concept of the ICS, the benefit of the ICS, the principle of the ICS. Now we proceed to the casting method. So here is the measurement technique, how you going to measure circumference of the stump. So what you need to do, you need to measure at the ischium level circumference of the patient stump. Then continue 2.5 interval down. It depends on the stump length of the patient. Okay? And then after that, after you understand the patient's measurement, so you need to do an assessment of the stump so that you can set up the goal of reduction. Okay? So what assessment do you need in order to understand how much reduction needed from the patient stump in ICS? Anyone know what kind of assessment? Yes.
Okay, allow me to answer. So there are two things that we need to inspect on the stump. That is the consistency of the stump and also the length of the stump.
Alright. Okay, that's good. That's good. Thank you, Ahmad. So it's correct, yeah? So we should understand 2 points of assessment. First is the soft tissue of the stump. So we can call this one as a tissue consistency. Yeah? Tissue consistency, we can classify them into 3 classifications. Whether the stump is a firm, average, or soft tissues. It depends on the patient. So you can do assessment and check how you can ask the patient to contract their muscles of the stump and you try to rotate. If the patient not be able to rotate the soft tissue by yourself, by your hand, so we can classify into the firm. But if it can be rotated slightly less than 90 degrees, so it can be classified into average, or if it's over 90 degree, we can classify them into soft to very soft. You can also check the stump by classified into the length. It can be whether short stump, medium stump, or long stump. Consider as the short stump if the stump length less than 30%. If you compare to the sound side, 30 to 70% would be considered as an average or medium stump. Over than 70% would be a long stump. So after you understand your patient condition, you can determine from this chart. For example, your patient is medium stump length and the patient has an average soft tissues. How many percent would be? Yes, it's going to be 5. So 5% will be approximate tension value at ischial level. It depends how many intervals you have by 2.5 centimeter. So the reduction will be decreased by you move distally. For example, you have 10 intervals and then you have 5% at the most proximal one. So you can just divide 5 into 10 interval, which is 0.5. So you start with 5% reduction at the top, and then after that lowering down, reduce by 0.5 to become 4.5, 4%, 3.5% until it's going to be 0 at the distal end. Everyone understand for this one? Yeah. Okay, we move to the next part. So first, there will be identification of the location adductor longus tendon. Where is the position of adductor longus tendon? Yes, it's going to be a medial corner, right? Medial anterior corner. What about the ischial tuberosity? It's going to be at posterior medial, greater trochanter, lateral, ASIS, anterior proximal, distal femur, distal more to the lateral side, right? And any other prominence area, right? If the patient have any. So the case is that adduction angle of the amputated side, if no limitation to adapt, use the measurement from the sound limb. You get what I mean? If there is no limitation. But if adduction is limited at the residual limb, use the maximum adduction of residual limb. Yeah. For example number 1, adduction angle of the sound side is 11 degree. Adduction angle of the amputated side is 13 degree. Which one need to follow? Yeah? Sound side. Who answer sound side? Okay. Who answer amputated side? No amputated side? If no limitation to adapt, use the measurement from the sound side. So you're gonna use sound side. Alright. So example number 2. There is a case where the adduction angle of the sound side is 11 degree. However, the amputated side is only 7 degree. Which one to follow? Amputated side. Okay, so that's correct, right? So it depends on how the adduction angle from both sound side or amputated side. So you need to measure both. Importantly, to check if there is no limitation, just use the sound side. If there is limitation, just use the rail from the stump, so that the angulation or ability to adapt you will get in a correct position. So the case study like this: if you find the patient, when you do hip extension measurement, and the patient be able to fully extend without any rotating of the pelvic, what is your goal of flexion? 5 degrees flexion. Okay. If there is a case where the patient come to your clinic and the patient shown as quite short stump, yeah, and when you check the hip extension angle, you found out that the patient has anterior tilt, yeah, at 15 degrees of flexion. Yeah. What is your goal of flexion angle? 20 degrees. Very smart. Okay. Give applause to yourself. And the other arm should be follow the line of progression. If you measure later on with the goniometer, you will understand the skeletal is belong to male or female. Anyway, yeah. So for the male, it will be less than 35 degree. For the female, it's obviously different. It is going to be always be more than 40 degree. Okay, summary for the measurement procedure. Okay, you need to do landmark first, anatomical landmark. I think everyone knows about this one. Hip abduction and extension angle. You're still familiar with this one, right? Abduction angle. Okay, I'll ask you later on. Length of the residual limb to classify whether your length residual limb short, medium, or long stump. Ramus angle, skeletal ML, soft tissue ML diameter, iliofemoral angle, AP diameter, residual limb circumference, and sound side measurement. This all thing need to be taken during casting. Okay.
Is there any question?
Thank you for the opportunity for me to ask the question, such as also relate regarding the ESFD material. Okay. So, I will then ask, so based on my understanding, the ISD socket functionally better than QL socket. Right. It stands for what that's indicated for QL socket. Does it indicated for patient with a long residual length, while the ISD socket is for patient with short or very short residual length? If so, would the QL socket still function?
Okay, that's a good question. It's a very good question, actually. Yeah. So, as I said earlier, the socket has been reformed by time. In the transfemoral as well, it's reformed from at the beginning, in early 60, 90, 90, 30 something, before introduction in Angus. The transfemoral socket is in oval shape. Yeah. And after that, it's developed to pre-quad in 1950, and after that, 1970, it start to distinct each of the wall. We call it as the quadrilateral. And after that, in 1980, it started beginning to develop what we call as ischial containment socket. But there are many names of ischial containment socket from the history. But the question is, can the QL still be function in type of the case? In one type of the case would be, from the biomechanical perspective, as long as the patient has a movement of or sliding of the pelvic, there is a risk of the femoral bone goes to the laterally. Unless it will be minimized if the patient has a long stump, because it still has a good power of the adductors muscle to balance the force of abductors muscle to keep the femur in abduction position. But in making ICS socket, need extensive skills to make. It's quite complicated at first, but if you as a prosthetist later on get used to it with the concept, you might be able to provide ICS for everyone patient. Yeah. But I would say as the first beginner, try to learn the concept of QL first. If you have mastered in the QL, I'm sure that it's going to be easy for you to adapt to make ICS better. Okay? Does it answer your question? Okay, thank you very much. Applause to others. Enough? Okay. I would say enough for today. Thank you very much. And I hope you could make a summary of these topics. And I will open to the admin, the assignment, and you can post that in admin by tomorrow. Does it sound good? Okay, thank you very much. Wassalamualaikum warahmatullahi wabarakatuh.
Demikian pembelajaran pada mata kuliah Concept of Transfemoral Prosthetic dengan topik Casting Procedure for Ischial Containment Socket yang telah saya sampaikan. Pembelajaran ini tidak hanya menekankan penguasaan konsep dan keterampilan teknis, tetapi juga mengembangkan kemampuan clinical reasoning, pengambilan keputusan berbasis bukti, serta sikap profesional yang diperlukan dalam pelayanan prostetik yang aman, efektif, dan berpusat pada pasien. Saya berharap materi yang telah disampaikan dapat menjadi bekal bagi mahasiswa untuk mengembangkan kompetensinya sebagai calon prostetis dan ortotis yang profesional dan mampu memberikan pelayanan ortotik prostetik sesuai dengan standar praktik yang berlaku. Terima kasih atas perhatian dan partisipasinya dalam mengikuti pembelajaran ini. Saya, Raden Achmad Candra Putra, mengucapkan terima kasih kepada para asesor dan seluruh pihak yang telah menyimak video pembelajaran sebagai bagian dari pernyataan diri dosen dalam unjuk kerja Tri Dharma Perguruan Tinggi PDD-UKTPT pada aspek pengajaran dalam rangka sertifikasi dosen tahun 2026. Wassalamualaikum warahmatullahi wabarakatuh.